Hi, everybody. This is Erica Mello, and welcome to episode number 145 of Tough to Treat. And for those of you who have not listened to us yet in the new year, Susan and I want to wish all of you a very, very happy new year. And I actually just got back from Europe. I was in Vienna and Budapest. And for those of you who do listen to the podcast, you know that I love to travel, and it had been a while. So it was just nice to get go across the Atlantic, and it was a nice rest. I hope you all enjoyed your holidays. And this episode is a shorty. The last two episodes, if you have not listened to them, they were part of a webinar that Susan and I did, and we've gotten a lot of great feedback on it so far. So those were episodes number 143 and 144. They're recorded in two parts, and it's really about learning how to, growing your clinical expertise by learning how to treat the complex patient. And it actually comes with slides. So for those of you who have not listened to it, I would highly encourage you to download the slides for that episode. And the URL for that is toughtotreat.com/slides for 143 and 144. So as I mentioned earlier, this episode is a shorty, and it is an audio video that I did for a course that I teach called Decoding the Complex Patient. And it's just a snippet of one of the audio videos that I've done. And it's really entitled Manual Therapy or Not, hands-on, hands-off, or both, right? In my experience, it's unless the person, as I mentioned, you'll hear in the episode, unless the person just doesn't do well with hands-on. And there are a few people who don't. They don't like massage. They don't like to be touched. But you can get them moving, right? And that's going to be pretty obvious in their history. So I just wanted to give you a couple examples. I know this is our intro, but I wanted just to add on a little bit to the episode. So if you want to watch the video, you can probably just up there. We have our Tough to Treat YouTube channel, and the video will be up there. The actual episode will be up there if you want to just watch it as well. So are the days of passive, sort of lying on the table, hands-on treatment over? No, depending on the patient population that you treat, you absolutely need to do that, right? But you don't want the mistake of just doing that unless the person's like really acute. That's not the type of patient population that I see, right? I see the tough to treat ones, right? So, our hands at the end of the day they're facilitators of movement. And, do I do passive treatment? I do, but I really try to move the patient into dynamic movement. And I'm still releasing, and I'll give you an example in a second. Once you've figured out what your patient's driver is, right? Let's say their driver for whatever it is their shoulder. Okay. And they've got some mid-back pain and their driver is their shoulder. So, are you just going to sort of have them in supine or prone and release upper trap and release posterior cuff and release pec and serratus and, all those 4 or 5 muscles that attach in there, sort of willy-nilly? No, right? Because some of those muscles are what we call victims, and they're not the actual muscles that are causing your patient's non-optimal movement pattern at the glenohumeral joint, right? So that's a whole nother episode that Susan and I can do on how to sort of figure out what muscles are relevant, but a lot of it is clinical reasoning, right? So for example, if your patient's driver is their left GH, their glenohumeral joint, and their non-optimal patterning that you're seeing is medial compression. Like every time they lift their arm up, the shoulder medially compresses. The subscapularis is a big medial compressor of the shoulder joint. We know that. We've learned that, right? So that's a muscle that you would probably most likely want to test and release, okay? And once again, Susan and I can talk about that in a little bit greater detail. But we know that that's the subscapularis. Are you going to release upper trap? Probably not, because it's not a huge medial compressor of the shoulder joint. Serratus, some of the posterior cuff muscles, maybe. But you don't necessarily need to get them passively to do this. At the beginning, maybe. So hands-on, hands-off? Yes, definitely hands-on, right? But when your patient is moving along and they're moving along in their program, a lot of these relevant muscles that we need to put our hands on may not appear when they're just supine, especially as they're going forward in their program. A lot of it will come on when they're moving. When they're doing a seated arm raise, for example, you'll feel the medial compression above 90 degrees of shoulder flexion. You're not just going to, throw them back on the table and say, I'm just going to release your subscap. No, you're going to do it with movement, right? Because passively, that muscle is not turning on in a supine position at this point, right? So I think that's the clinical reasoning. Do we keep our hands on? Yeah, I mean, because we're at the end of the day, we're facilitating movement. We're changing brain maps. You can still put your hand on we'll use the left GH as an example here again. You can still put your hand on that left GH, and release the subscap with the other hand as the patient's moving. I do moving into an arm lift. I do a lot of supine work on the Cadillac. I have them go overhead with movement and I'm releasing as they move. Is that passive? Oh no. But that is hands-on. That is hands-on. So I think we need to change our version of hands-on, hands-off, because I think we're always putting our hands on patients at the end of the day, but we are doing it for different reasons. Are we doing it just to release a muscle spasm, or are we doing it to facilitate optimal movement, or both? It just depends on the acuteness of the patient and where they are in the program. You want to be able to do an effective release at the end. And because once again, as your patient moves further forward in their program, you're going to see different movement patterns as load increases. They're going to be turning on muscles that maybe that are not relevant or not optimal for their movement patterning. And so, there is one example in my practice that where sometimes I have to get them in the prone position. I'll use the prone position as an example, and I'll do some segmental kneading. KN, like you knead dough, KNEADING. And I'll do some segmental kneading in and around the thoracic segments of iliocostalis, longissimus, because sometimes those muscles are big compressors of the thorax. It depends on what I'm seeing with my patient, but I will get those patients in prone and I will do segmental kneading. I'll do some transverse joint mobs, things like that. Manual therapy is not just, soft tissue, right? It can be joint mobilization. And I do, especially with in the prone position, I will do a bit of that. Do some transverse joint mobs on the on the T-spine, and not once again because they're stiff. It's because a lot of that's neurophysiological. It will help reduce some muscle tone. So that is one technique I actually still do to this day, and it can be quite effective, and you do it as needed as the patient moves forward in their program. So Susan and I hope you enjoyed this episode, and if you're new to the podcast, hop onto our website toughtotreat.com. And you can get on our Clinical Pearls PDF list, and we'll send you some great Clinical Pearl PDF that I wrote a few years ago. And Susan wrote a beautiful piece on persistent pain and sleep. It's so important that we get good sleep, and our patients do as well. So once again, toughtotreat.com, and we hope you enjoy it. Hey everybody, welcome back. This is just a quick video on entitled Manual Therapy or Not. And to put it into context, I had a patient just about a month ago who came to see me. I was probably her third therapist, and I had her on the table and I was doing some dynamic release and breathing. And she said to me, she's like, wow, no one ever got me on the table like this before. And I was like, what? She said, no, they just put me in the gym. And I know that people do that. So the question is, when do you do manual therapy? When or not to do it? And I will tell you that there are patients who there are the less is more type. Okay. You will know that the first minute you meet them. Like, an obvious one is patients tell me, oh, massage makes me worse. Well, then you're not really going to get in there with your hands deeply or at all. It's just going to ramp their nervous system up. That's an obvious one. So there are some schools of thought where, they just they don't put patients on the table. They don't do a lot of manual work, and that works for them. Right. But I do believe that, depending on the patient, that, especially if they've had a non-optimal movement strategy for so long, there are ways to start them off on the table doing hands-on work. And that could be dynamic release. I did a video on that as well. It was different release positions. I think it was called a release work, or I forgot the name of it, but there are many ways that you can get the patient involved actively doing that. And I do believe that, we need to see and feel our patients, even if you're feeling them for 10 minutes, right? And I know sometimes in one of the places I used to work at, I had half-hour treatments. So, you're not going to spend 10 minutes if you need to get them moving, right? So now I treat patients for an hour. So, but having said that, I mean, sometimes, if you're trying to change a movement pattern and their impairment is an overactive superficial muscle, you need to start out getting them on the table and feeling that and doing some release work, however you want to do that. However you do release. It could be in any way that you do it, right? I tend to get patients, I do less passive these days and I do more active. So if I have, someone who I need to, release something in their shoulder, for example, I'll get them supine on the table. And if I'm doing work in their pecs, I'll have them drop their knees side to side. I'll have them lift their arms. I'll have them turn their head. I'm getting more active involvement. Then I'll have them sit on the stool and I'll have them put their arms on the table and I'll do work in the posterior cuff. It just depends on the patient. So I am getting them moving, but I'm doing hands-on work. So if you're in a practice where you really don't have a lot of time to do hands-on and you need to get them moving, put your hands on them and dynamically release them. So if you need to get them to squat better, if they're doing an exercise, get your hands on them and release while they're doing their movement. So that way you're getting the hands on, but they're actually moving at the same time. So I get patients a lot in sitting. I had doing, arm lifts, side bend, turning the head, thoracic rotation. I had a patient last week. I had him supine on the Cadillac. So he's supine on the Pilates Cadillac and he's doing a push through bar over his head. I was releasing his serratus as he was moving. So I was definitely doing hands on, but he was also moving. So if you don't have the time to do the in the room, the sort of passive work, I do think you need to start out a little bit that way, but I would progress them much more actively, but still doing hands-on, but you're having them move their head, move their feet, things like that, because you're going to release muscles in different movement patterns, because that's life, right? We don't lie on the table, we move as humans. So I would certainly do more dynamic release, but that's still manual therapy, right? You're getting the patient a little bit more involved, but you absolutely, are having them move. There's the one I do in sitting on the plinth. They're sitting on my stool and they're like this on the plinth with their arms. I do that fairly frequently. They're not on the table, but I'm doing manual work and their head's on the pillow and I'm releasing their lats or their cuff. They're turning their head. They're moving their arms. That's very effective. Right? So I think as the patient goes further in their exercise program, you need to do some of that dynamic release. And that is manual therapy, right? So manual therapy also is standing them, watching them doing a squat and putting your hands on them, trying to facilitate movement. That's manual therapy. Are you doing soft tissue work and releasing? No, not really, but you're training the brain and your input into their hands trying to facilitate an optimal movement pattern is manual therapy. Right, is manual therapy. So, it's not your traditional, soft tissue. You can do a 5-second release or put your fingers on a tight lat and try to get them to move better and have them step forward or squat or do whatever movement you want. And that's release work. That's manual therapy. So when people say, I don't do well with massage or anybody touching me, well, then you absolutely, that's not going to help, right? So, but I don't get many patients like that. I've had a few in my career, actually more than a few, that say just massage doesn't work. I don't tolerate hands-on. I'm like, okay, and they know that because they've been through it before. It's ramped their nervous system up. But I will tell you, and I did this on another video, people who are very hypermobile, you need to finish up with a movement. So if you want to, you can release with whatever you want, but you need to finish up with movement with them because they're going to walk out of there all like you've taken away their strategy, their old strategy. And people who are a bit stiffer, who are less hypermobile they can control that, but people who are very flexible can't. So you need to follow up literally with whatever movement it is. It could be squats, hands on the wall squats, skull crushers, seated arm lifts, whatever it is, heel raises. You need to follow that up. End the session with that because they'll walk out of there and they'll be worse probably. after. So I hope that helps, and see you soon.